Welcome back to Conditions of Periodontal Disease, and we left off with some pictures of atrophy, which is better known as recession, and here are those photographs once again. So we'll move to the next slide. So pre-pubertal or juvenile periodontitis is a severe rapid periodontal destruction, and it involves tooth loss occurring infrequently, though, in children and in teenagers. So it happens before puberty sets in, usually between the ages of 11 and 19 years old. So the prepubertal occurs before 11, juvenile between the ages of 11 and 19. It is usually associated with another contributing disease. The rate of bone loss is 3 to 4 times faster than typical periodontitis. So if a person is diagnosed with this, they are going to be in treatment for a very long time, and it's going to be very aggressive treatment. This is a person with juvenile periodontitis, and it looks like in this case their tissue is slightly inflamed, not terribly. They do have some calculus and plaque formed between the teeth, but if you look at the radiographs, there is a tremendous amount of bone loss for this person. Unfortunately, I'm not told how old this person is, but they are going to be losing some teeth probably sooner than later in their life. The next item that we're going to chat about is acute necrotizing ulcerative gingivitis. This is something that you can create an abbreviation for and call it ANUG. You've probably heard of that. This is an inflammatory destructive disease of the gingival tissues. There is usually a sudden onset of ANUG, and sometimes following an episode of debilitation of disease or acute respiratory tract infection. It can be caused by something as simple as a change in living habits. So if we go from day schedules to night schedules, that can cause this to occur. From not enough rest, from psychological stress can cause ANUG to happen. Another name for it is Vincent's disease. Here are a couple pictures of someone suffering from acute necrotizing ulcerative gingivitis. See the rolled, punched out look of the gingival tissues, and it just really looks painful to me. If someone presents in your office with ANUG, you will smell them coming, because the necrotizing, remember, means dying or dead already. So the tissue is dead, and dead tissue does not smell very pleasant. Other oral signs of ANUG is that punched out crater-like depression at the interdental papilla to the marginal gingiva. So we see that in this photograph right here. Gingival hemorrhage or pronounced bleeding at the slightest stimulation can occur with ANUG. Lesions are extremely sensitive to touch, and when I say sensitive, I mean extremely painful. There's a constant radiating gnawing pain that the patient is going to experience if they are diagnosed with ANUG. Oral signs, again, are grayish or yellowish-gray ulcers. If the ulcer is wiped off, it may expose a highly inflamed area. There's typically a complaint of a metallic foul taste, and the patient has pasty saliva, so their saliva kind of changes in consistency. In severe cases of ANUG, this could develop in a high fever, an increased pulse rate, a loss of appetite, and complaint of headaches, constipation, and insomnia because of the pain that is irradiating from their mouth. Treatment of this is indefinite, so we need to take a look at what potentially caused this to happen in the first place. If it is left untreated, it may result in progressive destruction of the periodontium. The disease may subside spontaneously all by itself without treatment, but can reoccur. One of the biggest things to treat ANUG is improved nutrition. Use mild foods, things that are very nutritious but not spicy or acidic. Avoid alcohol, tobacco products, and carbonated beverages because they will irritate tissues further. Make sure we indicate to the patient that they need to get plenty of rest to heal. And once that acute inflammation has subsided, it's really necessary to do a thorough prophylaxis to remove any of that necrotic tissue and explain them on improved home care practices. All right, the next one is occlusal trauma, the primary type. The primary occlusal trauma happens if it's considered the primary etiology of the factor in the periodontal destruction. This may occur because of a high restoration that was recently placed, too much force on an abutment tooth from a prosthesis. So if we have a partial that is hooked onto a tooth, or new implant or something like that, can cause this type of occlusal trauma. Drifting teeth from the loss of a tooth, or from teeth super erupting because they don't have an opposing tooth, and they can get into the path of another tooth. And then orthodontic movement can also cause occlusal trauma. In this case of the primary, there's no pocket formation, there's no altered levels of connective tissue attachment. There may be increased mobility of the tooth, there can be food impaction, there can be wear of the enamel or the crown of the tooth, and the treatment of this is simply to adjust the occlusion. The secondary type is with reduced ability of the tissues to resist occlusal forces. Bone loss may result from this marginal inflammation. The periodontium becomes more vulnerable to injury in the secondary type. This reduces the periodontal attachment area. The tooth may become weakened. To treat this, we're going to again adjust the occlusion and remove any periodontal disease that is present. The next type of issue is called pericoronitis. So this is an inflammatory process that occurs when the gingival tissue surrounding a partially erupted tooth becomes infected. It is most frequent in the mandibular third molar area, may be acute or chronic, meaning that it comes and it goes, which is chronic, or acute, meaning that it comes with a blazing force all at once and needs to have the tooth removed. A patient that has pericoronitis may complain of severe pain, foul taste, and swelling in the area, as well as a fever. The tissue around the tooth is going to appear red and swollen. The initial goal of treating pericoronitis is to control the infection. We're going to also instruct the patient how to irrigate under the flap with warm saline solution, salt water, and then can place a drain under the flap to help any infection be removed. The dentist can prescribe antibiotics and pain medication if it is necessary, and this all happens before the extraction or the removal of excess tissue. We need to get that infection under control before we do anything invasive into the body. So here's a drawing of pericoronitis. This is the third molar. There's a little flap of tissue that stays there because the eruption force isn't going to remove that tissue. So food and debris and bacteria and plaque live and fester under that area. Here are some clinical photographs. So this person had this flap. It was surgically removed. This person, you can see where they were biting on the tissue with their opposing teeth, had the tissue removed. This person has a really active infection. We can see that it's very inflamed back here, and probably the best thing would be to have that tooth removed, and rather than the tissue, as well as here. And this is really what the underlying problem is. The tooth is impacted. It is not going to erupt fully, and that tissue is going to lie right over the top of that, and possibly cause an issue onto the distal portion of that second molar as well. Periodontal abscesses are something that are very different from an apical abscess. These abscesses form in the soft tissue of a periodontal pocket. They are not related to the condition of the dental pulp at all. They're completely separate from that. These may be acute or chronic in nature as well. Acute problem is where the patient complains of a throbbing, radiating pain, extreme tenderness, sensitivity of the tooth, and also mobility. A chronic abscess means that it's been there for a long time. They've went through the cycle of acute where it comes and it goes, and then chronic is there are no symptoms any longer because the things are dying around the tooth. The goal of a periodontal abscess is to eliminate the infection, draining the pus or the exudate from the pocket, doing some gingival curettage, scaling and root planing, and then prescribing antibiotics and pain medication. Here's a look at a periodontal abscess. There is no disease of the tooth or the pulp, but since there is periodontal lesions, this has led to this radiolucency at the apex of the tooth, leading to an abscess. Destructive patterns of the bone. When the gingival disease has progressed to the deeper structures of the periodontium, resorption of the alveolar bone and loss of gingival attachment follow, creating a periodontal pocket. So the height of that alveolar bone is normally maintained by constant equilibrium between bone formation and bone resorption. But when resorption exceeds formation, bone is lost and the tooth loosens. That's where we have that repair that we talked about very early on in the lecture. And when the body is no longer able to repair, the resorption is going to result in bone loss. And we have a couple different types of bone loss. First is horizontal bone loss, and it's the most common pattern of periodontal disease. The bone is reduced in height, but the bone margin remains roughly perpendicular to the tooth surface. So these little yellow lines show where the bone once was and where it has receded to. And we can place another line here, here, and here for where the bone has receded. Vertical bone loss can leave a hollowed out trough in the bone alongside the root. This can generally be seen on a radiograph, but not always. Surgical exposure is the only way to determine the presence of the defect in some cases. Vertical bone loss will increase with age, and it's most commonly found on the distal surfaces of molar teeth. So in this case, that is not the case. This is happening actually on the mesial surface, but on this one, it's on the distal of the first molar, very large furcation involvement, and then this really deep vertical bone loss pocket and trough that's happening there. Furcation involvement refers to conditions of bone loss in which the bifurcation and the trifurcation of multi-rooted teeth are invaded by periodontal disease. The most common sites are the mandibular first molars, and least common is the maxillary premolar. So in this case, we have the bone dipping all the way down to the lower third of the roots, and in some cases you can see daylight through those furcation involvements in some teeth. These two conditions, fenestration and dehiscence, are quite unusual, and you can only notice these usually with a surgery. So fenestration is an isolated area in which the root is denuded of bone and the root surface is covered by only periosteum and overlying gingiva. So here we have the fenestration. And in French, fenêtre, la fenêtre means window. So we have a little window opening into the bone. The dehiscence is when the denuded area extends through the marginal bone. This can occur more commonly on facial bone and anterior teeth. The cause of these is not clear. So here we have the dehiscence. Periodontal procedures is scaling and root planing and curettage, gingivectomy, gingivoplasty, periodontal graft, splinting, osseous implants, periodontal flap procedures, and also osteoplasty.